All right, it is about 2:03, so I think it's okay if we get started. Again, this is Katie Cook, Telehealth Coordinator at North Country Telehealth Partnership here at AHI. We're going to shift the agenda around a little bit today, as I noted previously. We'll get our updates from DOH, OMH, and OASIS after Michael Hasselberg speaks to give those folks time to sign on. So to get started, our presenter this month is Michael Hasselberg, and many of you on this call may have heard of him before. He does sit on the work group for telehealth for the Regulatory Modernization Initiative, the first meeting, of course, being September 5th, and we will go over highlights from that meeting. Michael is an assistant professor of psychiatry and clinical nursing at the University of Rochester, and he is the director of Project ECHO and telepsychiatry there. Project ECHO was certainly not on his radar to implement at U of R, but he's done a fantastic job in doing so, and he's going to speak a little bit about that today. So I will hand it over to Michael to talk about his project.
Great. Are my slides up? Can folks see those?
I can definitely see, yes.
Oh, fantastic. Well, thank you guys for having me. And some of you may have heard of Project ECHO, Extension for Community Healthcare Outcomes, and some may not. Before I begin, I have some acknowledgements. I have a lot of grant funding for my work with Project ECHO. My current funding is up on this slide here, the Greater Rochester Health Foundation, the New York State Health Foundation. So I do just want to acknowledge the funders of this work. So a little bit of a background about myself and kind of how I got involved in this. When I joined faculty at the University of Rochester about 5 years ago, we didn't really have any telemedicine coming out of the Department of Psychiatry. And my chair said, if you're going to join faculty in this department, I really want you to kind of lead this initiative and build a telepsychiatry infrastructure. And I had no background in telemedicine. I was actually an Alzheimer's disease clinical trialist, but I wanted to join faculty, and I said, great, I will lead this initiative, and we'll build telemedicine in the department. And it made a lot of sense why my chair wanted us to do telemedicine. As we know, 5% of the U.S. population accounts for over 50% of all healthcare expenditures. And we call these folks those super utilizers. And when you look at these 5% of individuals, we know that 80% of these individuals have mental illness. When you talk about this super utilizer complex population, specifically thinking about the Rochester, the greater Rochester region, and about the 13 counties that surround Rochester. It's really kind of the catchment area of our university. We knew that behavioral health conditions were the third most frequently diagnostic cluster seen in our emergency department. And we also knew that these folks that were admitted into the hospital, they could have been admitted for medical comorbidities, but had a comorbid psychiatric illness. These folks were at much higher likelihood to be readmitted into the hospital again after discharge. The problem is we don't have enough psychiatrists to go around to meet this need. When we looked at again the 13 counties surrounding Monroe County, 8 out of the 14 counties are designated health provider shortage areas for mental health care. And several of these counties, there's not a single psychiatrist or psychiatric nurse practitioner for the entire county. And when you look at the federally qualified health centers in our region, psychiatry providers, specifically psychiatrists and psychiatric nurse practitioners, were the #1 discipline that was most difficult to recruit and retain. So again, there's a substantial need for reaching more patients at a distance. One potential solution to this problem was this Project ECHO model, which just kind of fell onto my lap. Initially, 5 years ago, we didn't have any funding, reimbursement at all really for telemedicine services in our state. So most telemedicine projects were funded via grants, and I was a good grant writer, so I put together a grant to develop a more traditional telepsychiatry model, essentially geriatric psychiatrists, and I picked geriatrics because that's my clinical specialty area, and essentially the geriatric psychiatrist at the academic medical center would assess an older adult patient in the primary care office virtually and hand that patient off to the primary care provider. Well, the funder who I was applying to the grant for, the New York State Health Foundation, they loved the idea of integrating behavioral health into primary care, but they weren't so excited about telemedicine. They felt telemedicine had been around for a long time, and it wasn't as innovative as they were hoping. And they had heard about this ECHO model coming out of the University of New Mexico, and they wanted to bring this innovative teleconsultation model to New York State. So Project ECHO is based on this idea that at academic medical centers, that's where you have all of the specialists and subspecialists. And it's based on this idea of kind of demonopolizing that subspecialty expertise and getting it out to the generalists in the communities, so primary care providers, long-term care clinicians. And it works similar to a traditional telemedicine hub and spoke model, where the hub being the academic medical center. But the way this model works is that at the academic medical center, you have a multidisciplinary team of specialists that sits around a boardroom table. And then, for example, primary care providers across the state video conference into this room on these usually bi-weekly ECHO clinics. And the cool thing about the model is the primary care providers can see all of the specialists at the academic medical center, but they also get to see all the other primary care providers up on video also. Within the model, the way this works is the primary care providers, they present cases to the specialist team, but the cases are de-identified. No patient names, no dates of birth, just enough information for the specialist to have a good discussion about the case and provide recommendations back. They also encourage the other primary care providers online to jump in and provide recommendations. And so these primary care docs, they get these recommendations back both verbally and then written follow-up by the specialist after. After a few cases are presented by the primary care docs, one of the specialists at the academic medical center will do 10 to 15 minutes of evidence-based didactics of what are the best practices within that disease specialty area that the ECHO clinic is focused on, with this idea that over time, as these primary care providers attend these ECHO clinics, they will start to develop the subspecialty capacity and have the decision-making support to better serve these patients in their own communities within their own practices. So by extension, now the academic medical center is helping serve lots of patients in various communities across the state. So again, this project started at the University of New Mexico, and it started about 14 years ago at this time, and it started in hepatitis C care. So essentially what was happening in the state of New Mexico at that time, if you were a patient with hep C, the only place that you could get treatment was by a few hepatitis specialists at the University of New Mexico. The great thing about hepatitis C is it's treatable, in most cases curable, but the medications that were used at that time were very dangerous, and the primary care doctors in that state didn't feel comfortable prescribing those meds. So essentially large clusters of patients with hep C were dying when they could have received treatment. So this hep C specialist, Dr. Sanjeev Arora, came up with this Project ECHO model, and he actually received a very large Robert Wood Johnson Foundation grant to get it started and actually study it to see if it was effective. And Dr. Arora actually looked at patients with hep C, and he looked at sustained viral loads, and he compared patients that were actually coming in person to see him and his colleagues at the University of New Mexico to a group of patients who were going to see their primary care providers who were participating in this ECHO clinic. And what he found was there was no significant difference between the viral loads of these two groups, and that was a big finding which was published in the New England Journal of Medicine. And if folks aren't aware, the New England Journal of Medicine is a very high-impact journal, and when you publish in that journal, things tend to take off, and that's what happened with ECHO, where ECHO didn't just stay within the University of New Mexico. It started started to spread outside of the states. And at this point in time, there are actually approximately 130 echo hubs across 15 countries in our world, and it's in over 30 states within the United States. Up until about 5 years ago, actually 4 years ago, this model had not yet come to New York State. And of course, I had received funding from the New York State Health Foundation to bring this model to this state, and specifically focus in geriatric mental health for primary care. And I'm going to be honest with you, after I was funded and I went down to New Mexico and I learned about this model, I was not at all optimistic that this was going to work in our state. I actually came back very pessimistic that this wasn't going to work, and for several reasons. I mean, the first reason is that our state primarily functions in a fee-for-service reimbursement landscape, and this model really has no place within a fee-for-service reimbursement mechanism. Nobody wants to pay for someone else's education. The other issue that I was concerned about this model was that my audience was going to be primary care providers, and we also know that primary care providers are stretched really thin, and I was thinking to myself, how am I going to convince these busy primary care docs to essentially leave their practices for an hour every 2 weeks where they get reimbursed by how many patients they can see in an hour, and I'm asking them to come to an educational experience where they're not going to be reimbursed. And oh yeah, I'm going to teach them to become experts not only in behavioral health, but geriatric behavioral health, where these patients are complex, they're time-consuming, and the reimbursement for these patients are horrible. And I said to myself, nobody is going to want to sign up for this thing. But I was pleasantly surprised, and we launched our first echo clinic in geriatric mental health for primary care in 2014 in September, and we did this clinic for a little over a year, and over that time we had 33 echo clinics, and we trained over 500 primary care providers, and we actually had about 70 primary care practices across the state that participated in this, and we averaged about 16 participants per echo clinic. As you can see here on this map, we had practices across most of the state outside of New York City and Long Island and the Hudson Valley region. And the reason why we didn't infiltrate into that area of the state was we just didn't have enough grant money for me to go down there and recruit practices. But we had primary care practices that were affiliated with large health systems, and those are those red dots, those are primary care practices that were affiliated with a health system in that region. We also had physician-owned primary care practices. We had federally qualified health centers and health services corporations, and even county departments of aging that participated in our echo clinics. Part of when we brought echo to the States, me being a PhD doctor, a research doctor, I was very adamant that we had to do a good evaluation of this model. And up to this point, there really was no evaluation looking at the return on investment or cost effectiveness of this model. And so, very early on, we partnered with Excellus, the large HMO in our region, around doing a good evaluation of Project Echo. And Excellus gave us access to their statewide claims data. And we essentially evaluated at the primary care practice level 33 participating primary care practices who had Excellus beneficiaries in them. And we were specifically interested in looking at those Excellus beneficiaries over the age of 65 who had psychiatric diagnoses, either by a CPT diagnostic code that was billed out of that primary care practice, or we also looked at psychotropic medications as a proximal indicator of a psychiatric diagnosis, knowing that primary care doctors tend to underdiagnose a psychiatric illness. And we were specifically interested in looking at high utilization outcomes like emergency department visits and outpatient visits and inpatient visits, and then expensive psychiatric medications like antipsychotic and benzodiazepines. We did see a trend down in these outcomes, and we almost reached statistical significance with ER utilization. Again, of these Excellus beneficiaries 65 and older with geriatric mental health diagnoses. And this was a pre-post evaluation. So we looked at claims data 6 months pre the echo intervention and then 6 months after the echo intervention. When we looked at the cost data, we actually did reach statistical significance for emergency room associated costs. Those primary care practices participating in ECHO, their older adult clients with psychiatric illness had lower costs for using the emergency department. However, I do want people to interpret this data with caution because we weren't able to control for anything. So it's hard to say for sure that it was the ECHO intervention that caused this trend down in utilization, but it was an encouraging finding. We also did qualitative interviews with the participants, the primary care participants in ECHO, and things that we learned is the primary care docs and providers, they really enjoyed ECHO. They felt more satisfied with their jobs. They felt that they were less isolated because some of these physicians were in very rural areas of the states, and now they felt like they were part of an interpersonal or interprofessional team again. They felt like when they implemented the recommendations of the ECHO specialist team that they had improvements in their psychiatric outcomes of those patients. But some of the barriers, of course, was the time commitment to come to these ECHO sessions was a barrier. Interestingly, two kind of major themes started to come out of our data analysis. The first theme was that the primary care physicians across the states, they perceived that only a small cohort of their caseload was of geriatric age. Even though epidemiology data disagrees with that, they felt that not many patients within their caseload was older adults. And they said to us, we really would love to have an echo of that we could present patients across the lifespan. And I took that to heart and wrote another grant which was funded, and we started a general psychiatry echo up for primary care. The other thing that we learned was that in the rural counties in New York State, it's essentially the primary care docs that are the hospitalists in the nursing homes, and they felt that the geriatric mental health echo would be perfect for the long-term care setting. And I took that to heart and wrote another grant which was funded, and we took our geriatric mental health echo out of primary care and we put it into the long-term care arena. So we launched our Project ECHO in nursing homes in December of 2015, and it was actually really good timing because the Disrupt initiative just started getting on its way, and our PPS, our Performing Provider System, the Finger Lakes region, actually picked the Nursing Home Behavioral Health Project as one of our projects, which was really focused on integrating behavioral health into the nursing home setting. And our PPS heard about us being funded to do this project, and they decided to partner with us. We've since, in our region of the states, we're, I think, up to 60 nursing homes across the 13 county PPS that participate in our nursing home echo. It's actually so many nursing homes, we have to have two cohorts of nursing homes running on opposite weeks of each other. To date, we've had almost 70 long-term care echo clinics, and we've had almost 3,000 participants across the nursing homes. And we're averaging much more participants than our primary care echoes, almost 45 participants per echo clinic. And these nursing homes are much more engaged and very participant engagement during the echo clinics. We launched our geriatric psychiatry echo back in December, and then in March we launched a general psychiatry echo for primary care. And specifically, I actually reduced the number of spoke sites for our general psychiatry echo, and I reduced them really down to our health system's accountable care organization, primary care practices, specifically because I wanted to do a more rigorous return on investment evaluation of the model. So by decreasing the spoke sites, I was able to then identify propensity match controlled practices so we can really better understand, is echo really reducing ER utilization and ER associated costs? And I should have the results of that outcome probably by the middle of next month. But as you can see, we've had some success with our general psychiatry echo, similar to the geriatric mental health echo. We've been going for a little bit over a year and over 500 attendees at this point. We're averaging a little bit more in the general psychiatric, a little over 16 attendees per clinic. So echo at the University of Rochester started in the Department of Psychiatry, but it didn't stay in the Department of Psychiatry. And others across my university started hearing about this model and wanted to start their own echo clinics in their own disease areas. And we've actually launched another nursing home echo in partnership with the Office of Mental Health for New York, down in the New York City Long Island region, and that echo started in June. We also have echoes now in palliative care, eating disorders, autism. We have a hospital medicine echo where we actually serve our health system's affiliate rural hospitals, and we work with their ED physicians and hospitalists around determining which patients are most appropriate to be transferred to the quaternary medical center and helping support them increase the acuity and case mix index of the patients that they are actually admitting into their hospitals. We also have echoes in Hep C, STDs, HIV, and most recently we had an ophthalmology-focused echo launch. We've had a lot of recognition for our work with Project Echo. I've done national webinars for CMS about our work with Echo. SAMHSA actually presented the university's work with echo and behavioral health to a congressional hearing. The Agency for Healthcare Research and Quality just identified our work with behavioral health echoes as being actually one of kind of the gold standard case studies and for this year, and published that on their website. We've had again some great experience with the Office of Mental Health, who is now collaborating with us to expand our echo across the state, and discussions with the Department of Health about how we can help best support other academic medical centers that may be interested in starting echo programs up. So what are the challenges about this model? As I said earlier, in a fee-for-service reimbursement landscape, there really is not a good business model for this. Actually, when we reduce ED utilization and reduce ED associated costs, large health systems like my health system actually lose money, because in a fee-for-service landscape we make a lot of money by seeing a lot of patients through our ED and keeping our inpatient beds at 105% capacity. The other challenge is that primary care providers, we all know, are very busy and stretched thin, and they only have so much capacity to join echo clinics. So, as echo continues to grow throughout the state, we have to be very cognizant to not overwhelm the primary care docs and throw 5 to 10 echoes at them at a time. So we got to make sure that we don't duplicate certain echo programs in different parts of the state. We do have some progress at a national level for some potential sustainability of echo. Before President Obama left office, he did pass into law in December, the ECHO Act, which actually requires the federal government to think about sustainable reimbursement mechanisms and proper evaluations for the ECHO and ECHO-like models. Across the country, there are already pilot tests going on, testing different reimbursement mechanisms for the ECHO model. Several states have looked into building it into their managed care plans and, of course, accountable care organizations and patient-centered medical homes. And then here in New York State, we're testing it within the Transcript initiative with, again, hopes that in a value-based reimbursement mechanism, actually ECHO makes a lot of sense and that there will be a sustainable reimbursement mechanism for this model. So what we have found is that the potential benefits for Project ECHO to the health system is that the overall kind of mission of this model is to decrease variations of care. And we want to get everyone practicing good, best evidence-based practices with the hope that when more people are doing best evidence-based practices, there are not only going to be improvements to patient outcomes and caregiver outcomes, but also kind of reduce overall costs of the health system. The other thing that we're finding is that this model can potentially reduce staff turnover, specifically in skilled nursing facilities, but also potentially primary care providers as they feel, again, more satisfied with their jobs being connected to an interprofessional team and having access to specialists they may have not otherwise had access to. So our conclusions thus far with the model at the university is it's a pretty robust model, and it does effectively increase access to specialists, especially in underserved areas of this state. As you saw, we're already expanding our ECHO programs to other diseases. We're also building ECHO within our telemedicine models, where actually ECHO can serve as a triage system, where if a patient's presented to one of our ECHO clinics, and we feel that ECHO alone is not going to be able to meet that patient's needs, if that presenting organization is partnered with us in one of our telemedicine initiatives, one of our providers offline will evaluate that patient provider to patient in our telemedicine, traditional telemedicine telepsychiatry programs. And again, we're already looking at sustainability. Our organization's partnered with Excellus to evaluate this. We're working with our ACO about potentially building this into some of the shared risk contracts between our ACO and Excellus and other insurers. And then again, the whole hope with Transcript is that the successful pilots within that Medicaid reform will sustain themselves once Transcript comes to an end. So we're hopeful that there will be some sustainability for this. So that's my presentation, and I don't know if we've got time for questions, but I'd be happy to take some.
Yes, Michael, there was one question regarding the video conferencing equipment requirement for participation in ECHO. Can you speak to that at all?
Yeah, good, great question. So the software platform that we use is Zoom. It's actually the same software platform that we use at the university for our more traditional telemedicine programs. The great thing about Zoom is it's a cloud-based video conferencing platform, and on the spoke end, the only thing that the spoke participant needs to have is internet access and a webcam-enabled device. We have patients that participate with their smartphones, iPads, laptop computers, and then on our end, we have, if you can imagine, a boardroom with 2 large screen televisions because we have got lots of spoke sites that come up on the screen, and we have a little bit more expensive a pan tilt zoom camera, and then Zooms run through a computer that's hooked up to the televisions.
Okay, thank you. And I believe there was a question from Maria, Kansas. Maria, you're unmuted. Just need you to enter your audio pin so that you can speak.
Can you hear me now?
Yep.
Okay. I'm a family physician, and we have been trying to incorporate a lot of integration in our practice. But one of the things that I hear providers say is that they're concerned as they step out of their comfort zone, you know, they're concerned about malpractice. And none of the programs make any mention about any protection as more and more of this responsibility falls on primary care.
Yeah, and that's a great question. So what we know about ECHO and the legalities around it are, you know, are unclear. We know that there across the country have not been any lawsuits specifically to Project ECHO. Before we began, we discussed it at great length with our legal counsel about what our liabilities would be through Project ECHO, and our legal counsel did not have any concerns about our specialists providing recommendations out in a de-identified kind of case-based education way. What I say to our spoke sites is to run it through their legal counsel, you know, if they have any concerns about liability. But in reality, you would actually think that this model would lower the primary care provider's liability, where, you know, if you didn't have access to specialists to bounce ideas off of and you're out prescribing psychotropic medications and something bad was to happen, you would be more liable than if you had access to specialists that you could run your questions by, and you can, you know, document that you talked to the ECHO specialist team, that that would potentially lower your liability if there was an adverse outcome. But you know, I think as this model continues to grow, I think the liabilities associated will start to become more clear.
Does that address your question, Maria?
Yes, you know, unfortunately, I think by more clear means that somebody's going to get sued, and it's probably going to be the provider.
Yeah, but like I said, Maria, I mean, I think, again, your liability would be probably lower if you had the ability to run your questions with a psychiatrist before you prescribed the med than if you were to just go ahead because you didn't have access to a psychiatrist and just prescribe the med anyways.
Understood. Understood.
Yeah.
Seems to be a question on how you recruit panelists for the ECHO clinics.
So, you know, again, the good thing about being an academic medical center is we have a wealth of subspecialty specialists on faculty within our medical center. You know, actually, it's not that difficult for me to find faculty interested in this. It's only, you know, an hour out of their week every other week, and they actually really look forward to being on the specialist team. It breaks up their day of seeing patients, and those of us who work in academic medical centers, you know, we chose to work at the university probably for less money than we would make out in the community because, you know, we like to teach and we like to educate. So our faculty actually get excited about participating on our ECHO teams.
Looks like Katie's line is dropped off there, so I'll kind of pitch it for Michael. I'd like to thank you very much. I don't see any more questions there. First of all, for the presentation today, but more so for your leadership in this area. Like you said, you kind of came at it as a skeptic, but this has provided and expanded the access to care for for a giant region, and really appreciate what you've done with Project ECHO.
Oh, thank you so much. Yeah, it's been a fun ride, and we're looking forward to seeing it continue to grow and support the state.
Right. So I'm going to switch it over now. If I can change the project back to Katie, maybe that'll fix the issue. Katie, can you hear us? She's dialing back in. Oh, Maria, I've unmuted you again, and you had your hand up there. Can you hear us?
No, no, just from the last question.
That was the last one. Okay.
Yep.
Just going through here. Sure everybody's questions got answered.
Can you guys hear me at all?
Oh, now we got you back.
Okay, I don't know what happened. That's weird.
That's all right. I did the best I could to hold it over for you.
Thanks. So my next agenda item, because she is on the line, was to get an update from Rayanne. I don't know if you guys already started talking. I apologize.
Nope, not at all. Just circle back on a couple questions, and we're ready for Rayanne.
Okay, yeah, and really just an update on anything going on in your department pertaining to telehealth, maybe an update on the regulatory modernization initiative, thoughts from the prior meeting, and update on when the next one will be. So I'm going to unmute your line and you're ready to go.
Okay, thanks, Katie. Is everyone here now?
Yes.
Okay, great. Yeah, I think a good segue from just joined a few minutes ago and just heard the end of Michael's presentation, but pleased to be able to provide an update on the Project ECHO RFA that the department issued earlier this year. We are now working with the 4 awardees for Project ECHO, for some new Project ECHO hubs on some budget modifications, and hope to have those contracts executed pending CMS approval, because these are being funded through our federal SIM grant from CMS. We don't anticipate any problems with the CMS approval, but just until then can't really give you a lot more information about the awardees. But we're really happy that those are moving forward, and that in the end it looks like there will be 4 new Project ECHO hubs kind of spread across the state, and with a variety of different diseases and health conditions that they'll focus on. So with that RFA, we really gave the freedom to the applicants to select what they thought was the disease or health condition of most of concern in their community, or that they had the expertise at their academic medical center to provide. And we were pleased to find a broad range of things that were presented. So there will be, let me pull up this, trying to remember from memory here, and I know one is going to focus on diabetes management, a couple will focus on infectious disease, behavioral health, dementia, children's mental health specifically, opioid use. So again, I think geography doesn't really matter with Project ECHO, because as Michael probably explained earlier in his presentation, the nature of the model is that you can really connect to anyone anywhere. But I think it'll be great that we will have other additional hubs in other areas of the state, and then those will serve those areas of the state as well in terms of referral patterns and access to in-person specialty care when that's determined to be necessary. So any questions? I don't know if you want to open up for any questions about the Project ECHO awards.
Don't have any questions that came through or any hands raised at this time.
Okay. And then the Regulatory Modernization Initiative, we had our first meeting on September 5th. And thanks to all who were there. Thanks to those that are part of the work group and actually sitting in on the meetings and providing a lot of very valuable feedback to the state about your barriers and challenges and the things that you think need to change in terms of the regs and statutes that we have to kind of move things forward. From the department's perspective, we were really pleased with how that first meeting went in the broad range of stakeholders that came to the table and all of the discussion that took place. Also pretty pleased to see that there was kind of overwhelming consensus. There wasn't a lot of ideas or concerns that were raised that usually there were multiple stakeholders who agreed and said, yes, this is something that needs to be addressed. So it really helps to give us a focus for the coming months and year and the upcoming legislative session, and that's really the purpose of these regulatory modernization groups is to really focus the agencies on where to go next. So we will be having our second meeting on September 27th. At the September 5th meeting, I announced that one was canceled, but because we had a request from the work group to have that session hosted in Albany, we were able to accommodate that and keep that original date. So the meeting is primarily going to be in Albany. We will have a second location in Buffalo as well. So there will be video conferencing between the two. And as the last one was held, it will also be webcast and archived. So for folks who can't attend either of those locations, they can still view the live webcast or view it at a later time. So there will be more information going out about the agenda for that meeting. It will be here in Albany, in the same exact meeting room that it was held last time, in meeting room 6 on the concourse at the Empire State Plaza. The Buffalo location will be the Department of Health Western Region office, and there's, I'm not sure of the particular meeting room inside that building, but that will go out with the invitations. We are just going to ask again that folks RSVP to which one they are planning to attend so that we can make sure we have enough seating for any members of the public that want to attend either of those locations. And I think that's pretty much it, unless there are other questions.
That is exciting that it will be in Albany. I'll certainly make a point to attend, and I know many folks on the call also will. Will there be a transcript of the first meeting available soon?
The transcript is actually available if you go onto the webcast site. It's accessible through the Department of Health website. I think it's from the main page. You go to webcasts, and then you can go to archive webcasts and scroll through the list and find the date of that meeting. When you pull it up, you can view the video, but you also, there's another tab that you click on that says transcript, and you can print the transcript, or you can a new feature that I wasn't aware was available in there, you can do kind of a search and find for specific words, and it will jump to that particular part of the video. So if there was if you attended and there's a part you wanted to re-listen to, you can use that transcript tab to find that spot in the video that you are interested in viewing.
Okay, excellent. I will look for that link and share that with the group because I have been on that website before. I don't see any other questions for you. I think, Andrew just sent me the link, so I'll share that in my meeting notes, so thank you. Again, the meeting date is the 27th, and it's being held in Albany and Buffalo, so that's exciting, so more people can attend.
Mm-hmm. And I should also mention that we continue to take any comments. So if you viewed the first webinar and you have anything you want to add to the discussion or echo anything that was raised, you can always send comments to our regulatory modernization email address, and that's simply regulatorymodernization@health.ny.gov. That's also the same email address that you use to RSVP to the meeting.
Excellent, thank you.
Thank you.
Our next agenda item is an update from OMH, particularly Amy Smith. I also have a few questions for her that were sent to me ahead of time. So Amy, if you have any brief updates for us, please let us know. You are unmuted. Otherwise, I'll move right to the questions that I do have.
Okay, thanks, Katie. Just to do, I guess, really a quick update, we're looking to expand our regulations. I know we've talked about this before. We're internally reviewing a draft document, and we're really looking to expand to the different professions, so social workers, psychologists, licensed mental health counselors, and a few other small changes that we're still kind of working out here internally, and we're hoping to have something out by the end of this year. So that's just the update about the regs, and I can take whatever questions are out there.
Sure. So I have a couple of questions. The first one, per your current regulations, does the hub site need to also submit an attestation form for approval, or is that the spoke site only where the patient presents?
Only the spoke site is responsible. It's the spoke site that does the administrative action, so they're responsible for all the documentation that goes along with that, which would be the attestation, the policy and procedure, technical guidelines checklist. Yeah, just the spoke site.
Okay, thank you. Second question is it the provider rendering the service, aka the hub site, or the office where the patient sits, the spoke site, that bills for the service?
Per our regulations, it's the spoke site where the client sits. So whoever is responsible for that client, where they're physically sitting, that's who would bill that program.
Okay, thank you. And then the last question is more geared towards the Disrupt Integrated Services waiver that is obviously in conjunction with the other two agencies for Project 3AI. And the question posed was, how would this integrated services waiver impact any previous criteria outlined by OMH?
You know, that's a good question. It's something I'd have to follow up with others on because I'm not involved with the disrupt piece of things. But I can certainly, touch base with Keith about that. If you could, can you maybe email me that question directly, Katie, and then I can bring it to him and get it to the others that would answer it? Yeah. That would be helpful.
Absolutely, and then I'll provide an update to the group once we have some more clarification.
Perfect. That would be great. Thank you.
You're welcome. I don't see any questions that have come in from the group for you, so thank you for that update, and we certainly look forward to any new regulations that are put forth.
Great, thank you.
And last but certainly not least, if she's available, Sarah Osborne, I do see she is on the line. If there are any updates from OASAS for us, perhaps when you might be releasing practice.
Yeah, hi, this is Sarah. Can you hear me?
Yes.
Hello? Okay.
Yes, we can hear you.
Okay.
Okay, I'm sorry. Let me turn on my speaker here. We're still working out some final details. Hopefully we'll get everything done, I certainly hope by the end of the year. So that's where we are.
Okay, thank you.
Not much more to report. Thanks.
No problem. Okay, and then moving on to our final agenda item. Oh, there's a wicked echo. It's just an update on the North Country Telehealth Partnership. I hope everyone can still hear me. My phone has been wonky since I signed on. Corey, can you still hear me?
I can.
Excellent. So the only real two updates I had was I also wanted to provide a quick update about the Regulatory Modernization Initiative meeting that happened on September 5th. Just to highlight some of the key takeaways, one of the interesting stats that was put forth by DOH was that of the $63 million spent on both fee-for-service and managed Medicaid last year, only $350,000 was spent on telehealth, which is a big indicator that providers are not billing for Medicaid and are instead seeking contract arrangements with their spoke sites. So just something interesting to think about and a surprising stat. In terms of the overall theme was that that we're trying to maybe over-regulate telehealth, and how can we break down the silos that have been created. Each department has their own regulations, and how can we work towards standardizing those across all 4 agencies, including OPWDD, which is also looking at telehealth regulations. There was also immense discussion around allowing telehealth in patients' homes. And one of the public speakers, Dr. Irina Gelman, stated that in Fulton County, where she's the public health director, at least 75% of her population has a smartphone or access to one. And that metric is likely similar across all the counties that we represent. And really the next generation is going to demand this type of service, so we should also be focusing, not only on the elderly population and those with chronic conditions, but, working parents, college students, just something to think about for the future as we move towards, hopefully, more standardized regulations. And there was also some discussion around payers and providers and wanting flexibility and incentives to provide telemedicine. Simply just if we could remove that administrative billing and regulation burden, then access would be so much easier for the practices that we work in. Because telemedicine does cost a bit more, and not just from a monetary perspective. You have to think of additional workflows required, training of staff, hardware and software, billing components, credentialing. There's a lot that goes into it. So really that meeting was about identifying, what are the problems, and the next few meetings we'll discuss, how can we solve them. So I really encourage anyone who can attend in person to attend in person, or at least log into the webcast, and I'll be providing links with the meeting notes to do so. And then the only other update I have before I turn it over to Fort Drum is, of course, a plug about the North Country Telemedicine Conference. I'm sure you've seen me spamming your inbox with updates on that. It's November 2nd, and it's in Lake Placid at the Crown Plaza Resort. It's a one-day event from 8 a.m. to 4 p.m., and we have an exciting agenda. Many of the agencies on the line today are put on a panel. So, of course, if anybody has questions for Rayanne or Joan Sicard, Ronald Bass, Keith McCarthy, Sarah Osborne, or Deborah Eagle, please send those to me ahead of time so that we can compile them for the moderator to have a smooth discussion. There's about 30 spots left for registration, and I do anticipate those selling out. So please register before it is too late. Robert or Corey, do you have any other updates?
Bob, do you want to?
No updates from me. No, I don't have an update at this time. Do you guys hear me?
I think just overall, from this side, we're working on a retinopathy project right now to try and close some of those gaps. We have very low scores for closing or getting the results back for digital retinopathy for diabetic patients. So we're working on that right now. And so as that kind of kicks off and gets moving, we'll have more updates on that.
Excellent. Well, if there's no other updates, then we'll wrap it up for today. Thank you, everybody, for joining the call. I certainly appreciate it. And if any of you are going to the AHI Summit this week on Thursday, please find me. I will be working the registration table and would love to meet you face-to-face if we haven't met already. Otherwise, I will make sure I will be in attendance at the September 27th RMI meeting. And the next Learning Collaborative is set for the 16th of October, and that's a Monday as always, so look forward to that invite to come. So thank you very much. Have a good day, everybody.